Patient has an upper GI bleed after necrotizing pancreatitis. They have varices on endoscopy. What do you think was the cause of all this? Well, it's probably splenic vein thrombosis. And so think about the anatomy of where the splenic vein is. I have a picture here of your pancreas. You can see where the splenic vein is at. It's right at the top and behind the pancreas itself. And so severe necrotizing pancreatitis can cause cytokine release and inflammation into that splenic vein. And so this can cause thrombosis from all the inflammation, and you can eventually get bleeding because a backup of the blood, increased pressure, and you can have variceal bleeding. So if you see varices, don't just jump immediately onto cirrhosis. A lot of people do this, and this is not the way to get these questions. So see the entire question stem. If the patient's got a history of severe alcoholism, maybe it is cirrhosis. If they have severe hepatitis, probably is cirrhosis. But if the patient has necrotizing pancreatitis plus varices, you want to start thinking of splenic vein thrombosis. All right, but what about hepatic vein thrombosis? This is also known as Budd-Chiari syndrome. And so these patients generally will have jaundice as well. So they'll have hepatomegaly, portal hypertension. They'll have jaundice, which the splenic vein thrombosis will not have. So if you know your anatomy, these questions are pretty easy. But if you are a little bit shaky on your step 1 anatomy, think of what kind of clues can clue you in. So if you see pancreatitis plus varices, you're thinking splenic vein thrombosis. If you see jaundice plus thrombosis of a vein and you don't know where it is, it's probably going to be the hepatic vein, aka Budd-Chiari. So moving on, number 3. Patient comes in, they're in a seat collar, they're unstable, they have a cervical and thoracic spinal injury by your exam. You feel a step off in the back, and meaning that when you're feeling the vertebrae in the back, there's a huge drop off at one of them. So you're thinking that there's some kind of an injury there. So if this patient is in shock, they're going to have bradycardia. And this bradycardia is due to the decreased sympathetic tone. This is extremely important because whenever you see shock, generally the patients will be tachycardic. But if it is a neurogenic type of shock, you will see bradycardia. So always keep that on your differential with a low blood pressure plus bradycardia. Because remember, your heart's going to try and keep a consistent cardiac output. But if there's no sympathetic tone, it's not going to be able to raise the heart rate to compensate for the decreased blood pressure. Okay? So number 4, patient has a history that sounds like, let's say, prostate cancer, and now they have low back pain and new neurologic symptoms. You want to get an emergent MRI to evaluate for metastasis of the prostate cancer to your spine and new resultant Cauda equina syndrome. So Cauda equina is basically bilateral lower extremity weakness. You're going to oftentimes lose deep tendon reflexes, bowel function, bladder function, might even say that there is poor rectal tone, and these patients are going to have saddle anesthesia. So if you suspect that there is metastasis to the spine with new onset neurologic symptoms, the neurosymptoms mandate an MRI immediately. Number 5, patient gets hit in the head. They're in football practice, or maybe they were mugged, and now they have clear fluid draining out of their ears, draining out of their nose. What is that? That's a basilar skull fracture. The fluid that drains out is going to be CSF. You can monitor it by seeing that it's high in chloride. I got that TQ from Goyan back in the day. And so you can get the CSF draining through your nose via the cribriform plate fractures. All right, so here's kind of a good picture that I liked. You see basilar skull fracture can be through, let's say, the cribriform plate, the temporal bone, etc. You're going to see the raccoon eyes. These patients are going to have blood behind their eardrum, so hemotympanum, and they'll often have the battle sign, which is post-auricular ecchymosis. You really, really want to know these things to clue you into basilar skull fracture. They're almost always going to have a very prominent history in these question stems, such as getting hit in the head with a baseball bat or something like that. But you need to know the things that can be associated with the basilar skull fractures for those next step of association type questions. All right. Number 6, patient has basal cell carcinoma. They get an excision. Let's say that they have it right here on their cheek or on their ear. They excise it and it looks good. It's completely healing up a couple months later. But the doctor gets in contact with the patient and says, hey, listen, there is path on the little excision that we did that shows that the tumor goes clear out to the margins. What should you do? Well, because the tumor was shown to be at the margins of the pathology sample, you have to do a re-excision. And students miss this question all the time because they're like, I would just watch and wait, see if it recurs. The wound is healing fine. I don't see any more basal cell carcinoma, but that's wrong. You want to do a re-excision of the excision site, even if the incision appears well healed. And it's because you might have missed some of those cells, because if the pathology shows the tumor went clear out to the margins, You didn't get it all. So you have to go back in and re-excise whatever you just excised. All right, sounds counterintuitive, but I've seen it tested on the NBME. That's why I'm sharing it. Number 7, patient comes in, they have tons of burns, especially if it's like 20, 30% of their body surface area. What's your next step in management? It's always going to be to replace fluids immediately. And they'll give you other answer choices that are very tempting, such as give them nasal cannula or do an escherotomy so they don't get compartment syndrome. You want to replace fluids ASAP. As long as they're stable, then give them the fluids. All right, so here's Parkland formula. This is going to be the formula you actually use in real life to calculate fluid replacements in patients with burns. So you take the 4 milliliters, multiply that by the body surface area percentage, so let's say 20%, and then multiply that by their weight in kilograms, and that's going to get you 50% of that is given in the first 8 hours, and then 50% is given in the resultant 16 hours. So basically, they're going to get all that volume within 24 hours, but you front load 50% of it into the first 8 hours. All right, number 8. This is something that can trick you. Patient has a benign sounding injury. Let's say they scraped their knee, they hit their elbow. They did something that sounded kind of like what happens on a day-to-day basis, right? And the patient usually will be a diabetic. But now you see that the patient has severe fever, crepitus at the wound, aka gas in the tissues. You want to be thinking necrotizing fasciitis. Anytime on the boards you see gas in tissues, as well as in real life, this is really bad. And so this is going to be something like gas gangrene, necrotizing fasciitis. So the treatment is going to be immediate broad spectrum antibiotics because basically their fascial planes and their muscles is just disintegrating and the gas is just infiltrating up into their tissues. So you want to put them on vancomycin and piperacillin plus tazobactam and clindamycin. The clindamycin helps with the toxin production from necrotizing fasciitis. Give these patients fluids, get them stable, put them on pressors such as norepinephrine, and then take them to surgery to excise and debride the wound. They will never get better with just antibiotics from my experience. You have to take them to the operating room and cut out whatever the necrotizing fasciitis is. Okay, so if they have a leg wound, got to cut out all that tissue. I'm talking like huge amounts of cubic centimeters of tissue. All right, here's a trick question with necrotizing fasciitis that I've seen a couple students miss before. They see all these gas bubbles in the x-ray and it says, what's the next step? And they'll have MRI as an answer choice to get a better qualification of the actual extent of the necrotizing fasciitis. This is wrong. This is too slow, first off, but second off, necrotizing fasciitis is a clinical diagnosis. The gas in the x-ray can help you clue it in, but this is not required to actually diagnose it. So you definitely don't need an MRI. These patients go emergently to the operating room, put them on antibiotics, and ship them down to the OR as fast as possible. In real life, I've actually had to do these massive necrotizing fasciitis debridements at bedside because the patient was too unstable to even go to the operating room. So that's how severe this is. Number 9, patient comes in, they have a mid-shaft humeral fracture. Now they can't extend their wrist. What nerve is it? That's your radial nerve injury at the mid-shaft of the humerus. So remember, your nerves of your humerus are ARM. So A for axillary, R for radial, and then M for median. So it literally goes down your arm. The mnemonic is arm, ARM. All right, number 10, patient comes in, they're post-op, let's say 6 hours from a big surgery. They had an X-lap in their abdomen. They're now hypertensive, tachycardic, and in such severe pain that they can't really move. What's your next step in management? Look for the answer choice that says increase the dosage of pain medicine because the sympathetic tone is going to cause all their vitals to shoot upwards. So they're in a ton of pain, they're grimacing, they're squeezing down. You want to give them more pain medicine so they're more comfortable. That'll fix the hypertension and tachycardia. Number 11, let's say a patient has a central line or they have a PICC line, and now they have a fever, bacteremia, and an erythematous indurated vein, and there's pus actually draining out of the catheter. What is this? Well, it's going to be catheter-associated septic thrombophlebitis. And so the treatment is going to be broad-spectrum antibiotics and then excise the vein itself to get rid of the nidus of infection. If there's pus literally draining from a central line or some sort of catheter, that's pretty bad. That's like a huge, huge deal in the hospital because central line infections can be devastating because it goes directly into your central venous system. So remember, if you just see regular old superficial thrombophlebitis, you would never do all that stuff. This is if you just have septic thrombophlebitis with like pus draining out of it. If it's just a regular thrombophlebitis, you elevate their arm, elevate their leg, put on a warm and cool compress, give them some NSAIDs, some Tylenol, that kind of stuff, and they get better pretty quickly. So totally different pictures, even though they both have the word thrombophlebitis in it. Look to see the one that's septic or just superficial. All right, number 12. Something I want you to know for your exam is pulmonary emboli can present with lungs that are clear to auscultation. They might not have any murmurs or gallops or tenderness or edema of their lower extremities. That is okay. It can still be a pulmonary embolism on your NBMEs or your USMLE. And so do not let all the negatives throw you off if you are super convinced that the patient has a PE. So maybe they have a history of pancreatic cancer. All the cytokines make them hypercoagulable. Maybe they're dyspneic and tachypnic. All right, maybe they're tachycardic. Maybe they're immediately post-op, so they've been immobilized. All these things can clue you into a PE, but don't let the negative findings of clear lungs, no tenderness in the lower extremities, don't let that throw you off.